I'm ready. Good afternoon, everyone. My name is Jun, and I'm third-year PhD candidate in biostat at School of Public Health. Today, I'm going to talk about how to extend our long COVID study findings to better understand its impact on Chicago's COVID-positive population. First, let's talk about what is long COVID. Some people who have been infected with COVID-19 can experience long-term effects after their first infection, and we call this condition as long COVID. According to CDC, nearly 1 in 5 adults can experience symptoms related to their infections, such as fatigue, symptoms that get worse after physical or mental effort, difficult thinking, and etc. So if you feel bad after COVID infections, you are not alone. Actually, there's a large variability in long COVID symptoms. Some people are more likely to develop long COVID or spend long time to recover. Furthermore, some communities are at higher risk of both getting infected or develop long COVID. For example, I show 2 plots which show the 2020 COVID cases and community vulnerability by community area in Chicago. You can see they are really different area to area. To better understand long COVID and to enhance recovery, National Institutes of Health launched a recovery study with our UI Health being one important institution to study long COVID for our Chicago population. However, since there is a large variability in long COVID, it's really important to consider whether study sample recruited from UI hospital is representative of Chicago's COVID positive population. To answer these questions, I collect data and conduct research. First, I show the distribution of study samples by community area. From this plot, we can see most of the patients are from this dark green area, which is near west side community area. Then I plot out the distribution of community vulnerability index of our sample versus Chicago COVID population. The vulnerability index measures the vulnerability of the community. The higher the score, the more vulnerability, the more vulnerable. And you can see from these plots, UI Health disproportionately recruits patients from communities with low vulnerability, the right one, compared to our target population, the left one. And this difference is significant. This indicates long COVID study findings based on the UI Health site cannot generalize to Chicago COVID population. However, how to improve generalizability when we have biased sample? One way is to do reweighting. We can try to upweight those underrepresented subjects while downweight those overrepresented subjects to make our study sample close to the target population. I apply this method to our recovery study findings. So this plot in the left, I show the original recovery study findings of symptoms prevalence. And right one is the after reweighting the adjusted symptoms prevalence for the Chicago population. And we can see that all the symptoms prevalence is higher than the normal. That means there's a long COVID effect. And also, after reweighting, the prevalent symptoms changed. For example, the prevalent rates of pain, vision problem, and sleep problem increased, while the prevalence rates of mood and gastrointestinal symptoms decreased. Then let's come to our conclusion. The patient population recruited at UI Health may not be a representative sample of Chicago's COVID positive population. After reweighting, we can get a more accurate estimation. And the last one is the key take-home message I want to express for this lightning talk. To improve the generalizability of your study, it's very important to consider the target population and implement appropriate recruitment strategy or statistical adjustment. Thanks. Yeah.